All right. Hi, everyone. My name is Ella Ditzenberger, MCMS's newest membership and events coordinator. You might have seen my face before on the marketing emails, but I wanted to come on here and introduce myself personally. So if you ever have any questions or concerns regarding your membership, events, or anything MCMS related, feel free to reach out to me. September is Prostate Cancer Awareness Month. Prostate cancer is the most diagnosed cancer in men. Approximately 1 in 8 men in the United States will receive a prostate cancer diagnosis in their lifetime, with more than 99% of those men being over the age of 50. With that being said, I'd like to introduce leading radiation oncologist Ajay Bhatnagar, MD, MBA, as he discusses the latest in prostate cancer screening, diagnostic tools, and treatment pathways. We'll reserve the last 15 minutes for question and answer, or if anyone has any questions during the webinar, just put it in the chat and Dr. Bhatnagar will answer them accordingly. All right, take it away.
Thank you. All right. Well, today is a pretty broad topic on prostate cancer. So we'll try to get through it as quickly as possible, or as efficiently as possible. But I really want to highlight, the latest advancements in each aspect of the prostate cancer. As we go from the introduction, we'll talk about the latest screening guidelines, as well as the latest in the diagnostic testing, as well as the latest in treatments for localized prostate cancer, as well as the latest treatments for men with advanced prostate cancer. So let's get started. All right. As we already said, this is the most common malignancy, non-cutaneous malignancy in men. This year, over 300,000 new cases are expected. As she said, 1 in 8 men will be diagnosed, but for African American men, 1 in 6 men will be diagnosed. And so worldwide, we're seeing a doubling of the cases over the next 20 years, about 1.5 million new cases just this year. Uh, US, China, and Japan have the highest number of cases, whereas US, Nigeria, and South Africa have the highest death rates. Risk factors. As we mentioned previously, in the advancing age is the number one risk factor. Family history. Uh, there are these germline mutations such as BRCA1 and BRCA2 that we commonly discuss about breast cancer, but also relevant for prostate cancer. Um, Being of African American origin also it puts you at risk for prostate cancer. A high-fat diet, obesity, also linked to having an increased risk of prostate cancer, as well as exposure to chemicals. Now, what about testosterone therapy? Okay. Is there a link between having taking supplemental testosterone, which is becoming quite common, uh, uh, is that linked to prostate cancer? So, technically speaking, the appropriate use of testosterone therapy in men with low testosterone does not increase the risk of prostate cancer. Clearly, the caveat here is that the appropriate use, it does not lead to that. Because we do know that testosterone therapy can increase the PSA levels, which then can lead to a higher detection rate. That's not necessarily a cause-effect relationship. That's just more of a sampling and detection rate because of the increased rates of PSA. But we do at this time cannot state that increased testosterone therapy or supplemental testosterone therapy causes prostate cancer. I know that's a common thing that I get. That's why I wanted to make sure we talk about it. All right. Screening for prostate cancer has been, changed over the last 2 decades, and there's various specialties. But now, as of today, the specialties have gone in fairly decent alignment. And the main starting point is that they all recommend starting with a discussion with the doctor and the patient about getting screening. Okay? And so everyone talks about this as the starting point for prostate cancer screening in terms of discussing the risks and benefits of proceeding with prostate cancer screening. And so after that discussion, if they want to proceed or not, and how often, is definitely where the art of medicine comes in. But the current guideline is that we are emphasizing that this is a decision that is made between the patient and their physician. So when we look at the different societies, when do you start screening? And generally speaking, it's about age 50 for average, or well, it's age 55 for USPTF, 50 for average risk. For those with high risk, okay, which would either include Black ancestry, germline mutations, or family history, it's 45 or 45 to 50, and then age 40 if you have more than one first degree relative by the American Cancer Society. Now, what comprises screening? The basic screening at this point is still the PSA blood test and the digital rectal exam. However, after years have gone by and causing a lot of controversy and a lot of um, reasons to not do screening is the DRE. And so, do we really need to do the DRE for prostate screening? And technically speaking, not really. The recent studies have shown that there's actually a limited diagnostic value, especially for young men with high PSA, because as we'll get into it, we have other modalities, especially the prostate MRI, that can be much more diagnostic than the DRE. Technically, it's still recommended, but if the patient does not want DRE, PSA alone is a reasonable screening. So, if your patients are not interested in DRE, that's not a reason not to proceed with prostate screening with a PSA blood test. So, what is the right number? Okay, and it depends on several things. Age is the first, but as well as prostate size. The larger the prostate, the larger the PSA can be. But that also sort of correlates with age, as since the prostate can get larger as you age. And then medications. If someone's on finasteride, that PSA value is lowered. So when you have a PSA of 4 on finasteride, that's actually a PSA of 8. And that's, concerning. And what are the ideal PSA levels? So for age, when we're less than 50, it should ideally be less than 2.5. When you're 50 to 69, it should be less than 4. And then age 70, it ideally could be less than 6.5 before we start figuring out, before we should elicit the ultimate test, the biopsy. But now, in our modern era, we have ways to reduce unnecessary prostate biopsies. Okay? We have blood tests, such as the PHI and 4K scored blood tests, which are basically more sophisticated forms of the PSA. We have urine genetic tests to also help us determine whether that patient with an elevated PSA that warrants a biopsy. But really, the gold standard is the prostate MRI. All right. this is not only becoming very effective in detecting cancerous lesions and helping us figure out who to biopsy, it's also figuring out where to biopsy, which I'll show you in a minute. Here is a nice diagnostic biomarker test to show you all the different tests we now have with prostate cancer, starting with screening to help us figure out who to screen, who then to biopsy, and then with treatment how to guide the treatment. So right now we're just here, and I mentioned these tests that can be used to help with figuring out who to biopsy when you have an equivocal PSA. Okay. Um, but as I mentioned, the MRI is becoming the standard. And here is an example of an MRI that we use a what we call a PI-RAD score. In breast cancer, the mammograms use a BI-RAD score. In prostate cancer, we use a PI-RAD score. And so once we have, with the beauty of this is that we not only then, quickly decide that we need to proceed with the biopsy, we also now can figure out where to biopsy and can actually use these images to guide the biopsy, which significantly increases the detection rate. So, yeah, the ultimate and the only diagnostic test as of today for prostate cancer is the biopsy. This is really the ultimate way of determining this diagnosis. The traditional transrectal ultrasound biopsy is still the gold standard, where we're taking two samples from each sextant, the apex, mid, and base from the right side and left side for a total of 12 cores. But we now are able to do an MRI-guided fusion biopsy where we able to fuse those MRI images to the ultrasound and directly where the needle should go to take those samples from those highly suspicious lesions seen on MRI. And that really has increased the rate of the biopsies. There's also now the transperineal prostate biopsy, since these needles will now go through the perineum rather than the rectum, and has recently published shown a significantly lower, well, a statistically significantly lower infection rate, which is now also starting to be more commonly done. It's just that it does take quite a bit longer and techniques longer than the traditional ultrasound guided biopsies. So that's one of the reasons why the transrectal is still commonly done, but this is now becoming up and coming given the new data to support its very minimal low infection rate. So when we do the biopsy, the pathologists look under the microscope and give the prostate cancers a scale, use the Gleason scale to grade how aggressive the prostate cancer is. And they look at the largest area of cancer to give a primary score from 1 to 5, and they use a secondary, the second most largest area to give a secondary score. Okay. And so usually most commonly we'll start with the 3+3 as a Gleason score of 6. Okay, all the way to the Gleason 5+5, 10 being most aggressive. So it's a scale of the aggressiveness of the cancer. However, we now have a new grading group. Okay, so instead of using a Gleason score, we have translated this into a grade. Okay, so the Gleason 3+3 that we considered as the most sort of least aggressive cancer now has a score of 1. Okay, the Gleason 3, and this is nice because the Gleason 7s are separated because we know that the Gleason 3+4 is less aggressive than the Gleason 4+3, so we can now separate them as in this new grading group from group grade 2 versus group grade 3. So you'll see this now in most pathology or biopsy reports. You'll see right now still both of these reports, but that's the rationale of using this new group grading that pathologists use. Once we have diagnosed prostate cancer, most men are going through a staging workup to determine whether the cancer has spread outside the prostate. And the typical tests were the bone scan and CT of the abdomen and pelvis. However, we knew that prostate cancer was fairly poorly imaged on these scans. So it wasn't really until they were more developed that they would be detected. So we now have what we call the PSMA PET CT scan that is becoming the new standard for men with either intermediate risk, which we'll go into, Gleason 7 or higher, or with men that have a suspected recurrent prostate cancer. Okay, these are the two, so a fairly broad category in terms of men who are eligible for this scan that is much more sensitive to detecting metastases than the traditional um, modalities of the bone scan and CT scan because we're able to use this specific radioactive tracer, okay, with where the looking at this prostate specific membrane antigen, the PSMA, so which is expressed on all the prostate cancer cells. So we have a radio tracer such as gallium or FDG or F18 that is linked to this ligand here called PSMA that can help detect these cancerous lesions within the prostate or outside the prostate. We will be discussing how this is now translating into what we call theranostics, where we're diagnosing using this diagnostic radioactive tracer linked to PSMA, but we are now, which is really exciting, to be able to treat patients with advanced prostate cancer with a therapeutic radioactive isotope linked to this PSMA. And that is what we now call theranostics with radioligand therapy. I'm jumping the gun again, but this PSMA is really helpful in not only diagnosing right now, but will also be used, we'll see, for therapy as well. So, with localized prostate cancer, we like to use risk categories rather than staging of one, two, three, like an AJC staging like we do with other cancers. We like to use what we call risk categories to determine what treatment actually they would want. And when we're talking about risk, we're talking about the risk of the cancer spreading outside the prostate. Okay. And so we now have these six different categories: very low versus low, favorable, intermediate, unfavorable, intermediate, high, and very high. Um, and these are the way it's breaking down. And again, notice we're looking at clinical criteria here. Okay. We're looking at the PSA blood test, we're looking at the Gleason score, because I'll be showing you shortly how we are now also using genetic tests to determine their real risk and help us figure out what treatment they should get. So this is the classic clinical risk criteria that we have been using and traditionally and still use, but we are now added on to that genetic testing to help even further enhance our ability to discern what true risk they have. Uh, and so once we have figured out their risk category, that helps us figure out what treatment they have. All right. So, for very low risk or low risk, active surveillance is the recommended treatment. For favorable, intermediate, or unfavorable, it can, well, actually, favorable, intermediate risk, active surveillance is still an option. But for the other ones, it's generally by the NCCN guidelines, either surgery or radiation therapy where radiation therapy can be either, external beam treatment or brachytherapy. Um, and We will be talking about something shortly here about focal therapy. NCCN guidelines technically don't consider it an experimental treatment, but it is being commonly done in the very low risk and low risk category as an alternative to active surveillance, which I'll be discussing shortly. But these are the treatment recommendations according to what we call the NCCN guidelines. As oncologists, that's sort of the gold standard. Uh, and in very high risk, we have shown late recently that the combination of external beam treatment and actually brachytherapy actually has the best results compared to surgery alone or external beam alone. And we can actually even shorten the amount of androgen deprivation therapy that is required for these patients. And so as you can see here with the intermediate risk, we break it down to intermediate versus we break it down to favorable versus unfavorable. And you can see here with the unfavorable, there is the addition of androgen deprivation therapy, which is actually quite toxic. And so really a struggle can become is what intermediate risk are you? Do we really can we get away with treating you without the 6 months of hormones, or do we need to do it? And that's where the new advancements in the genetic testing has been very helpful. Active surveillance, okay? So obviously this means much more than doing nothing. We're talking about regular checkups, getting regular PSAs every 3 months, and even repeated biopsies. Okay, so this is a relatively active treatment that men need to when they're committing to active surveillance, they need to commit to this type of compliant follow-up care. And the whole advantage of active surveillance is to delay the potential side effects of the treatment, of the active treatments, such as a surgery, such as incontinence or impotence, because we know that 75% of men that are on active surveillance will eventually progress. We don't know how soon or how well, and therefore, we need to be making sure that we're following these men very closely. I personally have a personal bias where, men with high risk, such as African Americans or men with or have family history, in that that are in good health, that they consider an active treatment rather than active surveillance because of the risk of it becoming more of sort of letting it go and skipping it and becoming more aggressive. Because as you saw here, if they're still in the low risk category, they only need one treatment. If they remain on active surveillance and come back next year or aren't as compliant with follow-up, come back a year or two, and then now they're and get a repeat biopsy, and now they have Gleason 9 disease, and now they need to have more aggressive treatment. And so, for someone like that is young, that we know that can be able to that would be able to tolerate a single treatment quite well with minimal side effects. It's, in my opinion, better to nip it in the bud. But if you have an 85-year-old or older man with medical comorbidities, with a life expectancy less than 5 years, yeah, clearly this is the mainstay of treatment, active surveillance. Okay, so surgery, this is definitely the gold standard for healthy men with localized prostate cancer. And the ideal candidates are under age 70, because we know once you get over age 70, the risk of incontinence can be much higher, up to 20%. Having a BMI of under 30 is ideal for this, as well as having no pelvic surgeries. People who've had multiple pelvic surgeries would not be good candidates for robotic surgery. So what about focal therapy? What is focal therapy? And this is where we're only treating a part of the prostate. It's that guy that had just one core positive in that right base that we can now even see on MRI or PSMA. What about that guy? Rather than, he's a young guy that doesn't want to do just active surveillance, but doesn't necessarily want to put himself at risk for getting his entire prostate removed. What can we do? And so this has definitely become an emerging treatment for those for that kind of patient, and also now being commonly used for salvage treatment for those patients who have failed external beam and just doing a localized treatment. Uh, with the advancements in imaging, like MRI or the PSMA PET scan, that allows us to deliver this more focal therapy much more accurately and precisely. There are multiple modalities to give focal therapy. You may have heard about HIFU or the high intensity focal ultrasound ablation, nanoknife, aquablation, but focal brachytherapy is actually a really ideal treatment because of its ability to really contour the dose just around the individual lesions. Uh, here is an example of a photo where we're treating just half the gland. This is an ultrasound image of the prostate, and these are isodose lines, showing the radiation dose just to half the prostate. You can see that black air in the middle there. That's actually a rectal spacer that we'll talk about in a little bit. But this is where we've done what we call a hemigland implant. But with advances in imaging, we're now able to even be more precise than just treating half the gland. Here on the left is a PSMA scan where it shows that red uptake there. And this patient already had prostate cancer and actually had fiducial markers placed, for his prior external beam, but now has radiation come back in that area where it's uptake. Um, and we can then fuse that. We can also see that on the MRI scan that's on the right. And so now we have visualized this area of recurrent disease, and then we can then fuse it to our ultrasound, okay, which is how they do the biopsies as well, but it's also how we can do the focal brachytherapy and make sure I can implant the radioactive seeds just in that area. And as you can see, sparing the remaining part of the prostate, which allows us to spare side effects. In terms of other advancements in radiation therapy for external beam radiation, the main thing now is that we're doing the treatments much, much less. Okay. Historically, it would be 2 to 3 months of radiation treatment. We can now do the treatment in 1 week. Okay. And that's because the radiation machines are able to be much more focused and precise in their delivery. And therefore, we can give higher doses per fraction to allow a much more concentrated and a shorter course. We also now have rectal spacers, what I'll show you to protect the rectum from radiation. And this has been becoming now a pretty much standard for men getting radiation, whether they get external beam or brachytherapy, that can help protect the rectum from getting damage. And we also have, as I was mentioning, we just showed you focal brachytherapy, but we also now have this genetic testing to really personalize and individualize their treatment for radiation, specifically whether to add ADT or not. Here is just an example of showing what external beam looks like in brachytherapy. And I always just tell patients, oh, this external beam is coming from a source, coming from outside in, and therefore normal tissues are getting exposure, which is why I generally don't recommend external beam for younger men, because they're getting exposure to other areas of their body that could potentially result in secondary malignancies, such as bladder or prostate cancer or rectal cancer. In older men, it's not as much of a concern because it takes several years to develop secondary malignancies from radiation. But for younger men, it's something to be considered. With brachytherapy, it's what I call radiation from inside out. And therefore, it has minimal exposure to surrounding organs and therefore does not have that risk of secondary malignancies. Here is just showing a picture of how the external beam works. And this is the brachytherapy with the seeds. And proton beam. There is a facility here in town that has a proton beam facility. So I want you to understand what the difference is. And the traditional radiation machines uses what we call photons or X-rays. And so therefore there is entrance dose and exit dose from the coming outside. And while proton beam is a form of external beam radiation, it only has entrance dose. There is no exit dose, and therefore it can be much more focused and can deposit energy on the target. Okay. And this is a major advance for treatment. It's very expensive to develop. It's almost like $1 billion to have a proton facility, yet it's highly emerging throughout the country and very ideal for patients who have spinal cord tumors or pediatric tumors or brain tumors. And there has now been studies, is there a benefit for proton over photons for prostate cancer? And last year, the trial results were first presented at our society. And at this point in time, for prostate cancer, there really is no difference of whether you get protons or photons. And that's not necessarily knocking down proton therapy. It's really actually highlighting the advances in photon therapy that we now are much more targeted with what we call intensity modulated radiation therapy. We're able to do a really good job of it we don't really need to do proton therapy for prostate cancer anymore. Uh, Here is what we call the rectal spacing. And if you remember from medical school, that space in between the prostate and rectum, the Dennen-Vie's fascia, we're able to now place a gel or a water-based treatment or even a balloon, multiple different modalities where we can, inflate this Dennen-Vie's fascia to lift the prostate off the rectum and thereby spare the rectum from any radiation damage. There's several ones out in the market that this is done with a transperineal technique under ultrasound, and they typically dissolve, such as the Barrigel is a hyaluronic acid, the spacer is a hydrogel, and they both will dissolve over time, and highly effective in reducing rectal toxicity for any men undergoing radiation therapy for prostate cancer. So, getting back to this slide again, in terms of the genetic tests, we now have these tests, Oncotype, Prolaris, Decipher, to help us figure out who to treat, how to treat for their prostate cancer. So, let me show you some examples of this. Here, what they do is they take tissue, they take the biopsy results, okay, the tissue from the biopsies, and they run genetic profiling tests to then figure out how aggressive this cancer is based on these gene markers, okay? And they give you a score, okay? And again, these are just random, these are sample patients. And so here, this is a patient that may have what we call a favorable intermediate risk prostate cancer based on the Gleason score and the PSA, but the genetic testing has revealed that this patient is what we would call in the low risk category and therefore reasonable to undergo active surveillance. Okay. And so this can be quite useful for men deciding to undergo an active treatment or active surveillance. And so based on this study here, it would seem appropriate that they could go under active surveillance. Again, assuming these patients are willing to be compliant with the, fairly high intense follow-up care that's involved. It's one thing that they really need to be compliant with that. And on the other side here is what we call is an example of another genetic test was the Decipher test, where we are now that also is able to determine the prostate cancer risk spreading outside the prostate and determining whether it's at lower risk or higher risk of spreading outside the prostate and whether they would benefit from adding androgen deprivation therapy to the radiation therapy or to their surgery because of this risk score. And so this one has what we call a higher risk score and therefore would not only represent of getting what we have is of ADT, but also would also adding in additional hormone modulators such as abiraterone to further reduce this risk. So these is how the genetic tests can be used to help us navigate through the treatment options, in addition to just the clinical risk categories that we just discussed. Often not easy. Advanced prostate cancer, okay? And so this is for when men have disease beyond the prostate, whether this is identified on PSMA scan or this is just seen through a biochemical failure following treatment. And you know what the standard treatment has always been, starting them on androgen deprivation therapy, such as an LHR agonist called Lupron. But we know eventually there is a resistance that develops with them, and therefore they can be starting on other hormone modulators such as abiraterone, and then eventually they can then start with can go on chemotherapy. Okay, chemotherapy is usually Taxotere is the standard systemic therapy agent that has been used for advanced prostate cancer. However, we're really excited about the role of radioligand therapy for these patients with advanced prostate cancer. Okay. And so here there's a ligand bound to a therapeutic radioactive isotope that is able to deliver the radiation directly to the cancer cells to kill those cancer cells effectively with radiation and thereby minimizing damage to the surrounding healthy tissues. And this is what we call theranostics because we're using the diagnostic PSMA PET scan to identify the advanced disease, and then we're using radioligand therapy binding to that, using that same agent, the binding to this PSMA to treat the advanced disease. As of today, there is only one approved drug called lutetium-177 Pluvicto, but there are many other agents in the pipeline. Okay, by the time we do next year, there'll probably be 10 more. And this can be used for men who are with advanced prostate cancer or refractory to hormone treatments. This can be done even before chemotherapy now or after chemotherapy. And you know, this is using the PSMA agent, but this has application now to other cancers where you use different ligands, not correlating to those different cancers. So this is not just a therapy that has potential use for advanced prostate cancer, but for several others already being tested in breast and lung cancer. But the most development is here in prostate cancer. And here is a nice schematic here showing that the radioactive particle that is linked to the ligand, the PSMA, which is commonly expressed on the cancer cells. Therefore, all of these targets are very personalized and individualized of only targeting prostate cancer using that PSMA antigen. Okay. And then then gets internalized, and the lutetium-177 is actually a beta particle. So a beta particle actually has minimal penetration, and therefore it can just kill that actual cancer cells without any surrounding cells. This is actually an infusion. Okay. It's a blood transfusion. So this is administered through your veins and can travel throughout the entire body and specifically attacks any prostate cancer throughout the body. And as you can see, it's very exciting times for this era in advanced prostate cancer, whereas 15 years ago, there were very limited options besides Lupron. Sorry. And so, in conclusion, um, you know, as I said before, the prostate cancer is the most common and going to be even more common as it's doubling worldwide. The screening right now it consists of discussion with men and their doctor, and then proceeding with the PSA, whether or without the DRE. And if the PSA is equivocal, MRI can be used to help further the desire to proceed with the biopsy. That can also help with directing the biopsy to yield the highest detection rate. The PSMA PET scan is a high is a much more sensitive way of staging prostate cancer rather than the traditional bone or CT scan. And as we discussed with the new therapies with radiation, we're able to do much more shorter treatments, 5 to 10 treatments rather than 2 to 3 months. Even though proton beam is available, we have advanced the traditional radiation is just as good now for prostate. And as I mentioned before, theranostics is, huge advancements for advanced prostate cancer. And as you can see, I'm very, very excited about what holds in the future for men with prostate cancer, which is very important because given the the large number of people getting diagnosed uh, and then getting treated initially may eventually have advanced disease. So having more treatments for this advanced disease is going to be even more and more important. Um, and so with that, I'm going to end here. I saw that there were 2 questions. Um, I can put myself on the camera. Hi. Um, so, any questions? We went through a lot of information. Um, if there's anything that was confusing, please, I'd be more than happy to clarify. I hope everyone found this helpful in what's new in prostate cancer. Um, Otherwise, thanks a lot.
I have
I
one quick question. I'm sorry,
please,
I cut
please.
you before you head up. Um, is the genetic testing considered experimental, or is that now kind of mainstay, or how would you rate that as far as in terms of insurance coverage? Because I've seen that insurance is not covering it as considered experimental,
So,
which is pretty upsetting. So please
so
explain that to me.
Yeah, so as we talk about genetic testing, right, we're talking about what are we doing it for, okay? So if you have prostate cancer, okay, and you want to get Prolaris or Decipher, that they will approve that, okay? All right. And now and so then if you have an equivocal PSA and you want to order a urine PCA3 test, that should be approved. But if you want to get just a germline mutation without having it for a BRCA2 and not having any risk factors for that,
Right.
then yeah, then that probably won't get approved because that's the other one. So when we're talking about genetic testing, there's a lot of different these all fit under genetic testing, but
Well,
you know,
but if there's strong family history of prostate cancer and whatnot, and
yes,
even if everything else is testing essentially, negative per se, why wouldn't why is that considered
the
experimental? But
germline, yeah, the germline mutation because yeah, and for the general population, there needs to be, generally speaking, for BRCA1 or BRCA2,
hmm
there has to be more than just one family member with prostate cancer. It usually has to also have like someone either breast cancer or pancreatic cancer or ovarian, and they have to be diagnosed at a younger age. So those genetic tests for screening the general population can be more stringent. But once you have prostate cancer, these genetic tests are not that hard to figure out what treatment to get and how to treat,
right.
or if not to treat, are approvable. But you're talking about the general population. And you're right, because they can definitely be more stringent on that. But when we're talking about with someone that has a PSA that, that is 3.5, should we do these other tests to help us figure out whether we should get a biopsy or not? Yeah, that's generally considered, but they would have to have that PSA first and be in that equivocal range.
Okay. All right, fair enough. I appreciate your time. Very, very informative. Appreciate it.
Thank you so much. I really appreciate that.
Can I ask a question?
And then one more thing here is please, my last one is stay engaged. I really let's stay connected. Find me on LinkedIn or medias, and I'll be sharing more information on these platforms. So feel free to connect with me, and we will continue to disperse this information. And I really, as you can see, passionate about it, and look forward to educating more.
Can we get a copy of this of the slides, or do you have can MCMS they provide that, or?
Yes, this session's being recorded. So
Excellent.
tomorrow we're actually going to send you guys the CME link, and then you can also, whenever we get this uploaded or downloaded, we can also send you the link to that as well.
That's awesome. Yeah, because it's incredibly helpful. Thank you.
Can I ask a question?
Yes, please.
Oh, okay. Thank you. So just to confirm about the testosterone treatment on the patients that have, cancer that we have not found, and we give them testosterone, is not gonna make there's no receptors in the prostate cancer that is gonna stimulate the growth. That's what you were saying, correct? So we can do the testosterone without any risk for.
So we said, well, so men with low testosterone, okay, the appropriate use of testosterone therapy for men with low testosterone does not increase the risk of prostate cancer. Okay? So I want to make sure we clear that. So the appropriate use of testosterone supplementation in men who have been clinically diagnosed with low testosterone.
So less than 250 or 200?
I mean, that's a whole other discussion, but I think, but that's the main thing is that we're not talking about everyone giving supplemental testosterone to everyone.
Yes, I know.
I think the appropriate use, studies have shown that it does not increase the risk. That is correct.
Okay, well, thank you so much.
Hi, my name's Leslie Paulus. Have you heard of some Medicare Advantage plans denying the MRIs before the prostate biopsy?
So, as we know, Medicare Advantage plans are even denying my prostate cancer treatment sometimes. So I mean, they could be difficult. But I have seen lately a much more increased in this in improving MRIs. It can be they can't have multiple MRIs, but usually at least one. Especially if their PSA is in this equivocal range where we're trying to decide whether they warrant a biopsy. And so most men that I see now that have a diagnosis usually have an MRI in that workup period. 5 years ago, I usually saw them getting an MRI after they were diagnosed. Okay? Now I'm seeing these patients with an MRI before they were diagnosed as a part of their workup to not only help them figure out whether they should do biopsy, but also for them to help target where to place those needles to what to actually resulting in a much higher detection rate.
So basically a pill, if you see that.
Yes.
Thank you.
I have a question for you if you are still open for that.
Of course.
First of all, thank you. This was really helpful. I took lots of notes, screenshots, so I appreciate you being there. And for me, it was jarring to hear that the BRCA1, I'm retired, but it was jarring to hear that the BRCA1, BRCA2 profile also includes now prostate cancer. Would you recommend someone that already has prostate cancer, but young adult children, strong family history of prostate cancer? Would you recommend that they get BRCA1, BRCA2 testing?
And again, if they fit the criteria, the criteria for BRCA1, BRCA2 isn't just the family, but if it has several
Multiple.
criteria to meet. But if they have, but usually if there is a very young person with prostate cancer, even if they didn't have that germline mutation, they should get that germline mutation. But even if they weren't positive for that germline mutation, they obviously need to have very close monitoring of their prostate for screening for prostate cancer.
Yeah, someone that's already been treated, family
To
history.
help
that
their,
had
because you're
prostate
saying to
cancer.
help with their family members, right?
Correct. That's what I'm
Yeah.
concerned about.
Yeah.
So
So that's
diagnosis was
exactly.
early 40s.
And so what I'm saying is that you can actually just, and I don't know how young your child, the younger ones, but yeah, I mean I don't know in terms of the insurance of proving it or not. I have no idea, but their offspring definitely need to be under closer supervision for prostate screening, including getting that because like sometimes they would approve that son to get tested for BRCA testing, but not but that actual person himself. I mean, again, I've seen things all over the block, but it would be very reasonable for that person already with a diagnosis to have that to help their family members manage this potential diagnosis.
Okay. Thank you.
And hi, I just wanted to say hello. This is Dr. Jane Lyons. I'm the president of the Maricopa County Medical Society. And I just want to say thank you so much. This was a wonderful presentation. And Dr. Bhatnagar is a board member, and it's been wonderful to get to know him. And it was just a wonderful presentation. So thank you so much.
Well, hey, if a pediatrician was able to maintain her interest, that's pretty good. I'm gonna take that as a good. I'll take that as an A minus or A.
It was definitely out of my range, but I wanted to listen in,
No.
learn what you do. Although
No,
I
I
am.
get that, but I'm happy that you were able to stay interested and I really appreciate that because hey, you have men in your family, right? So it's important for you to know from that standpoint.
Yes, it was great. And then I just want to thank everyone for attending. We are so happy to be able to provide free CME to our members, as well as other physicians in the area. If there is any topic you're interested in, or you have a topic that you would like to talk about, please reach out to us. We want to provide more CME and things that people are interested in. So please let us know if there's anything you want to hear from or if there's anything that you want to present.